Hemolytic anemia. Hemolytic anemia is a blood disorder that happens when the red blood cells are lost more quickly than they can be replenished. Hemolytic anemia can be mild or serious and it progresses from fast or slowly. If the bone marrow's capacity to replace the lost erythrocyte cannot be maintained, a hemolytic anemia will manifest. The etiology of the disease is hemolytic can be divided in the aspect of the hemolysis, which is intrinsic and extrinsic. Intrinsic is the abnormalities in the red blood cells, which are known as inherited. The extrinsic is defects to the red cells occurs from the outside, which are known as acquired. Causes of abnormalities of intrinsic red blood cells are the metabolism of the cells, the membrane of the red blood cells, the structures of the hemoglobin present. And the causes of disorders extrinsic to the red blood cells are exposure to the toxins, abnormalities through the immunology, the hyperactivity of the reticuloendothelial cells due to drugs, and also infections. There are two types of hemolytic anemia, which is extravascular hemolysis and also intravascular hemolysis. So the pathogenesis of this hemolytic anemia, we will look into the extravascular hemolysis first. So most pathologic hemolysis is extravascular and occurs when damaged or abnormal red blood cells are cleared from the circulation by the spleen and liver. The spleen contributes to hemolysis by destroying mildly abnormal red blood cells or cells coated with warm antibodies. An enlarged spleen may sequester even normal red blood cells. Severely abnormal red blood cells or red blood cells coated with cold antibodies or complement are destroyed within the spleen and liver, which is because of its large blood flow. Can remove damaged cells efficiently. In extravascular hemolysis, the peripheral smear will show spherocytes or with cold agglutinants, erythrocytes agglutination if the blood is not warm upon collection. Next is the intravascular hemolysis. Intravascular hemolysis results in hemoglobinemia when the amount of hemoglobin released into plasma exceeds the hemoglobin binding capacity of the plasma binding protein haptoglobin. A protein normally presents in concentration of about 100 mg in plasma. Thus, intravascular hemolysis reduces unbound plasma haptoglobin. With hemoglobinemia, unbound hemoglobin dimers are filtered into the urine and reabsorbed by renal tubular cells. Hemoglobinuria results when reabsorptive capacity is exceeded. Iron is released from catabolized hemoglobin and embedded in hemosiderin within the tubular cells. Some of the iron is assimilated for reutilization and some reaches the urine when the tubular cells slow. The signs and symptoms of hemolytic anemia is pale skin, yellowish eyes, skin and mouth, which can be considered as jaundice, and also dark colored urine, high fever, enlarged spleen and liver, and also increased heart rate, and also weakness, dizziness. All these are signs and symptoms of hemolytic anemia. Screening and advanced analysis for hemolytic anemia is complete blood count test, where this is used to measure the hemoglobin and hematocrit levels, where a low level of hemoglobin and hematocrit is a sign of anemia. And the other blood test that can be done is reticulocyte count, where it measures the number of young red blood cells in the blood. So it shows whether the bone marrow is making red blood cells at the correct rate. So people who have this hemolytic anemia usually will have high number of reticulocyte count, as this shows that bone marrow is working hard to replace the destroyed red blood cells. The next test is Combs test. This test is to show whether the body is making antibodies to destroy the red blood cells. And the other test is haptoglobin, bilirubin and liver function test. This is the hemoglobin combines with a chemical called haptoglobin. So a low level of haptoglobin in the bloodstream is a sign of hemolytic anemia. The next test is hemoglobin electrophoresis. So this test looks at the different types of hemoglobin in the blood. So it can help to diagnose the type of the anemia that one have. The next is osmotic fragility test. This test is to look for the red blood cells that are more fragile than normal. So these cells may be a sign of hereditary spherocytosis, an inherited type of hemolytic anemia. Another test is testing for glucose 6-phosphate dehydrogenase deficiency. So in G6PD deficiency, the red blood cells are missing an important enzyme called G6PD. So the test for G6PD deficiency looks for this enzyme in a sample of blood. The next is urine test. This is to look for the presence of free hemoglobin. And last one is bone marrow test. Bone marrow test is to show whether the bone marrow is healthy and making enough blood cells. Okay, the last test is peripheral blood smear, where we can see in this slide there is a spherocyte for the first image. It's a microscopic image of blood smear. We can find these spherocytes. So spherocytes, the presence of these cells is due to the extravascular causes of hemolysis, which is known as hereditary disease. And the second one is cystocytes, and the presence of these cells is due to intravascular causes of hemolysis. The treatment for hemolytic anemia is blood transfusion, corticosteroids, and also folate replacement. The preventive measure for hemolytic anemia is that since it's an inherited disease, it cannot be avoided. Glucose 6-phosphate dehydrogenase deficiency is one of exception. If you were born with G6PD deficiency, can stay away from things that make it worse. Acquired hemolytic anemia can be avoided in some cases. One such example is the prevention of blood transfusion reactions, which can result in hemolytic anemia. This necessitates meticulous blood type matching between the blood donor and recipient. Okay, now we're going to look into the case study which is related to hemolytic anemia. So we can see it's a patient, 5-year-old male. Chief complaint is dark urine and fever. Past medical history is that recent history of upper respiratory infection following a spell of severe cold weather and a snowstorm, requiring treatment with erythromycin. Otherwise, he was previously healthy. Physical exam findings is on hospital admission, the patient was febrile, lungs were clear to auscultation, and the heart rate was regular. There was no edema or jaundice. And here is the lab findings of the patient. Okay, the first question of this case study is, what are these patients' most striking clinical and laboratory findings? So dark urine and fever, significantly decreased RBC count, hemoglobin level, and hematocrit reticulocytosis on hospital day 1 that resolved on hospital day 3 after transfusion of 5 doses of packed RBCs on day 1, 3, 2, and 4. Significantly elevated ESR, LD, and bilirubin, total direct and indirect levels, a reduced haptoglobin level, and a reddish urine with haze that contained detectable strongly positive 3-cell antibody screen results at 4 degrees Celsius, and positive direct antiglobulin test utilizing solely anti-C3 antiserum. The second question is, how do you explain these findings? The entire patient's clinical and laboratory data are in agreement with an in vivo hemolytic syndrome in a patient with an inflammatory condition, elevated ESR likely brought on by recent URI. prior EBF infection, positive DAT, and strongly positive 3-cell antibody screen results at 4 degrees Celsius, suggestive of red blood cells coated with a cold reactive autoantibody. The third question of this case study is, what are the principal causes of anemia? The second group, hemolytic anemia, can be further divided into two distinct groups based on the etiology. Anemia caused by an red blood cells membrane or enzyme abnormality, or anemia caused by immunologic factors that are not related to the red cells. Clinical signs of immune hemolytic anemias typically include rapid start and progression, dark urine, and jaundice with or without splenomegaly. Laboratory results are crucial in demonstrating an immunologic etiology and verifying a hemolytic process. The two types of immune-mediated anemia are primary autoimmune hemolytic anemia and secondary AIHA. The only clinical finding in primary AIHA is hemolytic anemia. There is no discernible underlying disease. The fourth question is, what is this patient's most likely diagnosis? Paroxysmal cold hemoglobinuria is the most likely diagnosis of this patient. So PCH is most likely cause of the patients due to the fast severe intravascular hemolysis connected to the patient's account of recent cold exposure. The fifth question of this case study is, what laboratory tests will be helpful in confirming the diagnosis? The serologic Donat-Landsteiner test is made to show that the patient's serum has the DL antibody, supporting the diagnosis of PCH. The P antigen complex, which is present on the surface of red blood cells, is the target of the DLAB. The sixth question is, what causes the patient's disorder and how common is it? An acquired form of AIHA called proximal cold hemoglobinuria is brought on by the serum of the patient having the DL antibodies. The P antigen complex is glycosphingolipid on the surface of red blood cells is the target of the DL antibody. An antigen with a structure like the P antigen on human red blood cells has been proposed as the stimulus for the development of this antibody. The last question of this case study is, what are the treatment and management of this disorder? The cornerstones of PCH treatment are supportive care and cold avoidance. All exposed body parts should be covered. Consumption of cold foods such as popsicles or ice cream should be avoided, and the affected people's living space should be warmed to around 700 degrees Fahrenheit. For symptomatic anemia and life-threatening hemolysis, pre-warm packed red blood cell transfusions may be necessary, especially to maintain adequate renal blood flow. I would like to conclude that there are numerous subtypes of hemolytic anemia within the illness process. For the treatment of their particular type of hemolytic anemia, patients frequently need a full medical staff and team of specialists. While many conditions can be treated with drugs or with simple avoidance of triggers to prevent complications, others can have dire repercussions. Patients need to be made aware of the signs of a worsening clinical conditions of the onset of infection that could result in further morbidity as a result of the illness process.